views. So the partial volume artifacts occurs when an off-center object projects partially into the scan plane, and inconsistencies between views causes streaking and shading artifacts. And this can be reduced by acquiring thin slices. So here you can see the streaking on the image is more visible compared to a thin slice where the streaking is absent. And photon starvation, when parts of individual projections can be very noisy due to insufficient photons passing through the widest part of patient. When these views are reconstructed, the noise is magnified, resulting in streaks. And this can be avoided using MA modulation, allows an increase of photon flux through widest parts without an unnecessary dose through narrower parts. So this is called MA modulation. We are not directly increasing, as and when required, where accordingly we are increasing the MA. You know, as MA increases, more number of electrons will be emitted out of the coil. So here you can see when we have to image the thicker part, we are taking more MA compared to when the body part is thinner. Or for the X-rays, the area to be, or the depth to be traveled by the distance to be traveled by the X-rays are lesser, we can use lesser MAs, and when we need to cover more tissue, then we can use the higher MAs. So this is called MA modulation. And undersampling, when two coarse a sample interval results in misregistration by the computer of information relating to sharp edges and small objects. Fine lines appear in the image, and avoidance of undersampling artifacts are done by use of high resolution techniques which increase the number of samples obtained by quarter detector shift or flying focal spot. And metal artifacts, streak artifacts caused by metallic materials present, and this could be due to the dental filling, prosthetic devices, surgical clips or electrodes. Avoidance of metal artifacts is by gantry angulation to avoid dental filling in the imaging field, or use of special software corrections. You know that avoidance may not be always an option, but we can use specialized software to correct these artifacts to some extent, depending on the size of the artifact, size of the metal object, and the amount of the artifacts present. And motion artifacts, voluntary and involuntary motion of the patient can cause streaking artifacts in the reconstructed image. So minimizing motion artifacts by reducing the scan time, utilizing short scan time, immobilization and positioning aids, alignment of tube starts position with primary detection direction of motion, overscan if available, averages repeated projections, and special software correction reduces weighting of views obtained towards beginning and the end of scan. So where if there is motion inlined in the acquired images or acquired views or acquired projections, that could be eliminated by corrections comparing the multiple images taken or the multiple projections taken during the scan. So here you can see a motion artifact, and which is the on the right side you can see a corrected image. Scanner-based artifacts are the result of miscalibration of detector in rotate-rotate geometry, and detector sensitivity can cause ring artifacts. So in third generation scanners, detector gain differences can cause circular artifacts to be present in the image. We have seen that in third generation, the arc of detectors move along with the X-ray tube. So this can cause a circular artifacts. The movement of this detector can cause an artifact in the image. And presence of circular artifacts indicates that the detector gain needs to be recalibrated. So from one acquisition to the next acquisition, the gain of the detector needs to be calibrated. The amount of X-rays detected and the amount of output formed by the detector needs to be adjusted so that these ring artifacts are can be eliminated. Helical artifacts. In the transverse plane, in general, the same artifacts occur in helical and conventional scanning. Additional artifacts occur in helical scanning due to the interpolation process. This is a result of changing structure in the Z direction. Example, at the top of the skull, and artifacts are rose at higher pitches, and minimization of helical artifacts can be done by reducing the effects of variation along the Z axis. Pitch of 1 rather than higher pitch, 180-degree rather than 360 interpolator, and thin slices. So all these allows us to reduce the artifacts in helical acquisition or spiral CT. Here are some of the pictures. Artifacts deteriorating the image quality because of the detector calibration issues. So, and cone beam and artifacts. With increased number of slices, X-ray beam becomes more cone-like. So spatial reconstruction needed to avoid cone beam artifacts. So when more number of slices are taken, the X-ray beam becomes more like, instead of a parallel beam or a fan beam, it will become more like a cone beam. So you can see that the problem with this. So when it becomes one cone and the another cone, there can be an overlap that could result in misinformation in the detector. So that is what is expressed over here. There is a lesion and the detector's image and image created using central rays and lesion correctly displayed if it is like this. If there is, because of the cone beam effect, this which is supposed to be here could be represented here over the detector. Coming to the advancements, multi-slice CT represents the latest breakthrough in CT technology, and here is a historical representation of what advancements came around what time. In 1971, Hounsfield invented the EMI scanner, 85 advances in slip ring technology, 89 introduction of helical CT by Siemens, 91 launch of dual slice, 99 launch of four slice, and 2001 introduction of 4 slice in India, 2002 launch of 16 slice, and 2003 16 slice in India. So the 2003 launch of prototype 32 slice scanner. So you can see that a lot many things happened in 2003. Prototype 256 scanner developed by Toshiba, research in flat panel detectors and research in faster scanning, that is less than 0.4 second rotation time, and research in cone beam CT with a mobile isocentric C-arm. The introduction of rotating envelope tube, the idea was first documented in 1917. This design is very close to the realized Stratron tube, having used magnetic and deflecting coils to deflect. Deflect focal spot 4640 times the electron beam for striking two area on the anode to get better Z-axis resolution. Anode being direct contact with the cooling coil enables an extremely high cooling rate up to 7 mHu per minute. So unique features of the Stratron tube had made the MDCT possible with improved workflow and increased resolution. The faster cooling will enable us to proceed with the procedures in a timely manner rather than waiting for the tube to cool down after acquisition of set of images. So this is the pictorial representation of how the Stratron two alternating focal spot enable two X-ray beams to pass through the body virtually simultaneously. So the deflection of the X-ray beams to fall on the two spots on the anode. And we have an array detector system with 0.6 and 1.2 millimeter collimation shown at the center of rotation. So this detector, as the tube as well as the detector array, needs to be aligned properly to get the proper imaging or to avoid artifacts at the same time. It enables us to have better imaging options. Single detector row replaced by 4 or more rows called detector array that enables simultaneous acquisition of 4, 16 or 64 slices during one gantry rotation. 3 types of detector array matrices are available. Fixed, all matrix elements are of same size, and adaptive, elements wider away from the center. So at the center it will be smaller and towards the periphery it will be wider. So for more clear images, more precise imaging, we need smaller elements. So the positioning and acquisition, focusing, aligning with the central axis, all those things becomes more important over here. And mixed is where all matrices of same size with the exception of a number of thinner ones at the center. So different companies adopted different techniques to produce their own system of producing a good quality image. So this is not just the only thing which causes the image quality. There would be other, like the acquisition is one factor, and how you process all that also comes into picture for in developing a better quality image. So here you can see the different systems in which the elements are arranged. So the thinner ones at the center and bigger ones towards the periphery. And here you can see thinner ones at the center, but all other elements are of the same size. So here you can see the Siemens proprietary adaptive array detector system with zero point 0.6 and 1.2 millimeter collimation. In the middle you can see 0.6 and towards the edges you can see 1.2 millimeter collimation, and it covers a total area of 28.8 mm across the z-axis. So 32 elements of zero point 0.6 and 4 elements of 1.2 at both sides, covering a 28.8 mm across the z-axis. Siemens has introduced the ultra-fast ceramic detectors. Construction not disclosed in the 1998. How great dynamic range, how high absorption and conversion efficiency, smaller in size, less calibration required. Only disadvantage is its cost. It's very costly, and advancements in hardware and software of CT has made it possible for present scanners to acquire and reconstruct the images with perfection. So this ultra fast ceramic detectors enables better image acquisition as well as the better heat dissipation, um, at the cost actually, and the dynamic range is higher and absorption and conversion efficiency of the detector material is better, and the total size could be smaller and the calibration could be relaxed. The very strict calibration protocols which needs to be followed to acquire good quality images could be relaxed while using these ultra fast ceramic detectors. And multi-detector row CT, so the dual slice, 4 slice, 16 slice, 64 slice and 128 slices in one rotation. So MDCT represents the latest breakthrough in CT technology because of its glimpsing features. It is a specialized CT system equipped with a multi-detector array that simultaneously obtains topographic data at different slice locations like 4, 16, 64 during one gantry rotation. The fundamental difference between MDCT and its predecessors lies in the detector array designs. We have seen how the multi-detectors are arranged and how they move in helical CT scan or spiral CT scan to acquire the images and cover more area in single rotation, making the whole scanning process faster and effective. So in single slice CT, one slice per gantry rotation is obtained. Single row of detectors is used and can acquire data fast as compared to conventional CT. Disadvantage is more scan time compared to the multi-slice CT scanners, and or multi-detector CT. Liable to misregistration. Retro reconstruction of slices is not possible in post-processing. So here are the pictures: pencil beam geometry, fan beam geometry and open beam geometry. We have seen all these things. So we have seen the fundamental principles, and now we are seeing its applications where it could be of use, and what makes it more feasible or more preferable or less preferable for different purposes. So multiple row detectors and single row detectors, how the imaging is done, how the slice is. So here you can see the more area will be covered in one go when multiple row of detectors are utilized. So the scan duration, significant reduction in scan time is achieved by the use of multi-MDCT, and reduced motion artifacts because the whole scanning is done in much lesser time. Resolution greatly enhanced contrast and temporal resolution. Ultra thin slices of intervals less than 1 mm or lesser, and single breath hold studies, single regional areas with thin slices scanned during a single breath hold, and IV contrast, faster scanning allow reduction in the IV contrast and higher injection rates. Tube usage, large areas scanned by thin slices without overheating the tube, and volumetric 3D data set, generation of rendering images like VRT, MPR, MIP, real-time dynamic scan, faster acquisition and shorter scanning time, benefits cardiac, musculoskeletal imaging, etc. And they have multiple detector rows, multiple acquisition systems, faster gantry rotation, high speed image reconstruction system, the unique Stratton tube, and multiple reconstruction techniques. The detector array is an assembly of multiple solid state detector array modules with multiple detector arrays, slice thickness determined by detector width, not by the collimator. And more than 30,000 detectors are placed in 2D array in longitudinal direction to enable better capturing of all the X-rays. Data acquisition system, we have seen that we have multiple options of data acquisition systems. So the signal from each radiation detector of a multi-slice spiral CT scanner is connected to a computer controlled electronic amplifier and switching device, more commonly called as DAS or DAS. It is the DAS that select the detector combination for signal summation. So interpolation method, different interpolation schemes is used, multi-point interpolation, or is where instant filtering takes place. All the data points falling inside a pre-selected filter width are taken into account equally in a weighted fashion. We set a window width and all the signals falling in that will be given a particular weightage and added to the image input data. The single and multi-slice helical scanning reconstruction, how we do that. We have seen how the single and multi-slice helical scanning is done. Here you can see a single helical scanning, and here the different colors represent different detectors, an array of detectors which does the helical scanning. In single slice interpolation, two nearest data points, the interpolation is done between two nearest data points, and a 4 to 8 slice scanners use all data within a variable filter width for interpolation. So here you can see 2 points near the reconstruction position is utilized, while we are setting a filter width for multi-slice CT scanners. We have seen the design, dual slice scanners introduced by Elsint in 1991, relatively easy extension to single slice, two parallel detector banks, two data sets per rotation, and slice width chosen by varying beam width. And this allows twice the speed of single slice scanning for the same slice width. Narrow collimation down to 2 into 0.5 mm. We have two slices and of 0.5 mm. Extended patient coverage for the same tube loading compared to the single slice. The 4-slice scanner got introduced in 98 and 0.8 second rotation time, faster coverage by the table feed or rotation, 1 to 2.54 mm collimation, and ceramic highlight detector with 1400 592 elements, improved temporal resolution to 125 to 250 milliseconds, and but motion artifacts are still present. So the start rotation time is very small, and the resolution is much better with the use of large number of detector elements, but motion artifacts are still present in fossilized scanner. Allows an eightfold increase in the performance compared to single slice cell helical CT, and all major manufacturers brought this, and multiple detector banks along the z-axis required for this, and between 8 and 34 rows used in practice, slice width selection using beam width and detector switching. So the detector switching for slice width selection. So the G light speed, the detector output compared to define data acquisition width. So here you can see different data acquisition widths across the z-axis. The detector output is used to define the data acquisition width. So here we have two 0.6 mm width detectors, and in here you can see 4 of 1.25 mm, and here we have 4 of 2.5 mm, and here we have 4 of 3.75 mm, and here we have 4 of 5 mm. So these detector arrangements based on the output uh, is output helps us to redefine the data which we acquired from the scan. The 16 slice scanner got introduced in 2002. Gantry rotation time is 0.4 to 0.5 seconds. We can see that it's half the time, and thinner collimation of 0.625 to 0.75. Ultra fast ceramic detector with 1600 128 elements, and motion free cardiac imaging for heart rates up to 80 beat per minute. So how the three companies arrange their collimators. So here you can see that there are central small ones, and at the periphery there are bigger ones, and for Philips they have more number of smaller ones in the center, and uh, bigger ones at the periphery, and while the other company Toshiba has a mixed pattern of smaller ones in the center, little bigger, then towards the outside we have multiple bigger ones. So here is a comparison of different features of multi-slice scanners. So you can see that most of the parameters are more or less the same. So for each company, they have set their own specific characteristics for their equipment. So length of the detector array, you can see all the four has 20 to 32, and minimum slice width is also in similar range, and minimum rotation time is also kind of same. So more than 16 slices, we have options of 32, 40 and 64 slice system. Acquisition. So this is acquisition plates, the detector mockup, the detector system, how the elements are arranged, how to get the very good quality images, or to acquire good quality images, or the output of the detector array, how it needs to be reconstructed to acquire a good quality image. All these combinations could be, we can have a combination of different things to acquire the desired result while we are taking the making the image. So here you can see the Aquilon has 64 detectors of 0.5 mm, and Aquilon 16 detector has 16 into 0.5 and 24 into 1, and 4 detector has 4 into 0.5 and 30 into 1. So here you can see the 0.5 4 ones and 15 15 each of 1 centimeter, and here 16 of 0.5, and then 24 12 12 each of 1 centimeter. So here we have all the 64 of 0.5. So same thing is represented here again in a pictorial graphical way. The covers, so the higher number of slices covered in shorter time uh, enables to image organs where internal motions or involuntary motions are there, but we can do the imaging, capture the imaging in between the normal physiological movement. So covers the entire heart in 5 heartbeats, and Gantry rotation speed is 270 to 330 milliseconds, and isotropic resolution of 0.4 into zero point 0.4 into zero point 0.4. So different companies have different names and different another comparison of different scanning system commercially available today with respect to the features. So the detector or slice number, resolution, rotation time, reconstruction time, and tube power for different 16 slice CT scanners from GE, Philips, and Siemens are tabulated over here. The GE equipment is called Lightspeed VCT, Philips Brilliant 64, and Siemens Somatum Sensation 64. So the detector or slice number is 64, and Siemens have 32 or 64. Resolution is almost the same, 0.35 and 0.34. Rotation time varies in each, 0.35 in GE, zero point 0.4 with Philips, and 0.3 with Siemens. And reconstruction time is for 16 images per second with GE, and 40 images per second with Philips, and 20 images per second with Siemens. And tube power is 100 kilowatt with GE, 60 kilowatt for Philips, and 80 kilowatt for Siemens. So you can see here, with lesser kilowatt we will have lesser number of photons, that will give rise to uh, lower data, lower amount of data which we have to process further to acquire a good image. So we can mix and use different permutations and combinations of different parameters to acquire the same quality images. We have seen this. It's again a recap, which is an important feature for image quality, scan protocol, and dose. Detector pitch is the table movement per 360-degree rotation of gantry divided by total beam collimation. Coverage for MDCT is the product of all these. The N is the number of data channels, P is the pitch or width of each channel, T is the total scan time, and R is the gantry rotation time. So the product of all this will give us the coverage in the longitudinal plane. So here is another comparison of different CT systems. The minimum slice width, minimum tube rotation, number of slices per rotation, number of detector rows, type of detector and type of detector array. And another important aspect is the quality control, QC and quality assurance. It is very important that we do the quality control program periodically to ensure the best performance of the equipment. So there are different tests which are recommended at different time intervals. So the noise uniformity test could be done weekly, and the tolerance is plus or minus 10 HU, and linearity, spatial resolution, contrast resolution, slice thickness, couch incrementation, laser localizer could be done semi-annually. So the tolerance of each of the tests, linearity could be more than or equal to 0.96 percentage, 96 percentage, and spatial resolution should be within the vendor specification, and contrast resolution 5 mm at 0.5, and slice thickness more than 1 mm slice and less than 5 mm for 5 mm slice, and couch incrementation plus or minus 2 mm, laser localizer plus or minus 1 mm, and patient dose and dose profile could be measured annually. So the patient dose from each of the procedures should be within the manufacturer specification, and dose profile variations also should be within plus or minus 10%. And periodic evaluation of the image quality, at least once a year, of the image quality obtained in each room allows the detection of malfunctioning in the imaging chain or in the generator, almost always associated to high patient doses when the quality is getting poor. And this could help us in establishing the DRLs, diagnostic reference levels, how we can increase or maintain the image quality at the same time by decreasing the equipment parameters or the exposure parameters. And maintenance of the logbook after evaluation is part of the quality control program. The periodic evaluation of the number of rejected and repeated radiographs and the analysis of the causes of rejects and retakes allow the detection of failures in the X-ray equipment associated with image devices, as well as in the examination procedures and in the skill and training of the staff. So this will let us know what we are doing, how we are doing, how good we are, all these things. So this is more of an audit program which we need to do in order to update and upgrade ourselves towards a better quality imaging program. There could be machine problems, there could be system problems, there could be other problems like electrical problems, engineering problems, humidity, temperature, all those problems. There could be practice problems like how the people are conducting the practice while they are acquiring the image, who is accompanying the patient, who is coming inside, all those things also, and what all results in repeat of the procedures. Evaluation of that will enable us to take precautionary measures to avoid them further happening in the practice. CT has experienced a rapid development from its beginning. Multi-row detectors, ultra-fast data acquisition systems, rapid reconstruction hardware, perfect reconstruction, and advanced viewing tools are the key factors to fully exploit the clinical benefits of this technology. The future challenges will be to make flat panel detectors CT in practice. It is expected that this machine will perform radiography, fluoroscopy as well as CT. and a situation of convergence with endless possibilities. So we are looking at reducing the patient doses from each of the procedures, and more number of slices will have more amount of data and more detailed imaging, and resulting in increased resolution, and as well as improved workflow, enabling the patient comfort as well as the uh, personal. That is all for today.
Ma'am,
That is, yes.
ma'am, dual energy CT, you will not teach us.
Yes, I will.
Okay, ma'am. Then
Uh,
image rendering techniques and that CT perfusion and CT diffusion, they are also the part of recent advancements
yes,
in
yes.
our CT.
Yeah, we will
Okay, ma'am.
see those also.
Okay, ma'am.